Good evening. Good evening and welcome. Thank you for joining us for another wellness webinar series event with Jefferson Health. My name is Nicholas Coffey. I am your humble host and program facilitator. This evening, I will present your questions to our panel of experts, and together we'll learn about healthy eating to prevent cancer and how to make smart food choices. Our experts will talk about the latest research on preventing colon cancer and why it's rising among younger people. They'll also answer your questions about the different screening methods for colorectal cancer so you can decide which option is right for you. Thank you so much for submitting your questions in advance. I maintain that we have the smartest audience on the internet, and you'll see that once we see some of these really terrific questions. The questions that you will hear from me were submitted by you, our audience, directly in the form where you registered for the webinar. So keep that in mind for future events. We look forward to hearing those questions in the future. If you have any questions tonight throughout the discussion, for those of you joining on your computer or tablet or other internet connected device, at the bottom of your screen, you will see an icon that says Q&A. We'll do our very best to get to as many live questions as possible, but we may not be able to get to every question during the event. Due to hospital guidelines and privacy, we are unable to comment on specific cases, so please keep that in mind as you submit some of those questions this evening. Without all that housekeeping out of the way and no more further ado, our experts for the evening, I'd like to introduce those here. We have Dr. David McCune from the colon, rectal, and surgery department, and Dr. Sue Kim from the colon and rectal surgery department, as well as Emily Holzman from nutrition. Thank you so much for joining us. We have a really terrific panel this evening. I'd like to give each of you a minute or two to say hello and give some background about yourself. And Dr. McCune, I'd like to start with you, if that's okay.
Yeah, of course. Thank you, Nick. My name is David McKeown. I'm a board certified colon and rectal surgeon, originally from Dublin, Ireland. I moved over here about 12, 13 years ago. I did most of my training in Philadelphia, actually at Jefferson Center City. I did my fellowship in New Jersey. I worked for several years in Western Pennsylvania before joining Dr. Kim's group as their most recent most recent employee. So I've been with them for close to a year, and it's been great learning a lot from them, and excited tonight to answer your questions and see how it goes.
Wonderful, thank you. And Dr. Kim?
Yes, thank you for having us tonight. Good evening. My name is Sue Kim. I'm one of the colon and rectal surgeons with the Colon and Rectal Associates. Dave, Dr. McEwen, and I are two of the six colon and rectal surgeons in our group. And so I started my career off, I did most of my schooling in Philadelphia and did my fellowship in Michigan at Grand Rapids, and then did a little bit of I spent a little bit of time at Temple University for 4 years, and then have been with my current group for, let's see, since 2007, so 18 years, just about. As Dr. McEwen said, we are all board certified colorectal surgeons, which is primarily what we do. And thank you again for having us. We're excited to talk to you about colon cancer.
Yeah, we're excited as well. Thank you. Finally, Emily.
Good evening, everyone. I'm Emily. I'm one of the registered dietitians at Jefferson. I currently work at Abington Hospital as an inpatient dietitian. I did my undergraduate at Penn State University, got my bachelor's in nutrition there, and just recently completed my master's in nutrition with Jefferson University. So I'm a very new dietitian, but during my schooling, I spent a lot of clinical hours at the Sidney Kimmel Cancer Center in Center City, as well as Asp Point Cancer Pavilion as well. So I've had a lot of interactions with cancer patients and got a lot of time to, educate them on what we're going to talk about tonight. So again, thank you. And I'm excited to talk to you all.
Yeah, we're excited as well. Again, appreciate this. We've got a very experienced panel here and looking forward to getting into some of these questions. So with that, thank you very much. And we'll dive right into our first question here. So this one's going to be for you, Dr. McEwen. The first one here, colorectal cancer is now occurring more frequently among a younger population. Do you see colonoscopy screening guidelines being lowered in the near future? And then I'll add to that, is there any research as to why this may be happening?
Thanks, Nick. So that's an excellent and very timely question. We've been seeing a worrying rise in colorectal cancer in younger adults under 50 in recent decades. It used to be a disease that we mostly saw in older patients over 50, but now it's appearing more so in people in their 40s, 30s, and even late 20s. In fact, over the last 30 years, cases in people under 50 have increased by about 50%. So by 2030, colorectal cancer is actually projected to be the leading cause of cancer death in people under 50. And that's a big wake-up call that colon cancer isn't just a disease of older patients anymore. So why is this happening? Honestly, we don't have a clear answer yet. There's a lot of research underway. People or experts think that our modern lifestyles probably play a major role. Younger generations today have higher rates of obesity, they're less physically active, they may consume more processed, high sugar or low fiber foods. So all this combination, which we call lifestyle and environmental risk factors, have played a part. There's also the microbiome that some people suggest
Mhm.
may be causing this. Some have wondered whether exposures to certain chemicals or antibiotics when we're kids, but all these links have not been confirmed. They're all theories. And genetics alone doesn't explain it because only about 10 to 20% of these early cases that we see are actually from inherited conditions like Lynch syndrome. In other words, most young patients are getting colon cancer do not have a strong family history or genetic syndrome. It's often coming out of the blue, and that's why it's so puzzling. And then the second part of your question was about screening age. So as you know, screening, colonoscopies, FIT tests, or Cologuard, this is how we catch colon cancer or precancerous polyps early. Because of the rise in younger cases, the guidelines have already started to change. Not long ago, most of the organizations used to start colon cancer screening at 50 for average risk patients. Now that's down to 45 in the United States. So we've moved it down by 5 years to try and catch cases earlier. Could we lower it even further to 40 or younger? That's a hot topic of debate. Some experts say, well, yeah, we could start it at 40, but there's a few things to consider. First, even though cases are rising in these younger groups, the overall number of colon cancer cases in patients in their 20s, 30s, and 40s is still relatively low. So we don't want to overscreen people unnecessarily and cause more harm than good. Also, there's a massive increased cost associated with screening people at a younger age, and that obviously gets passed on to the consumer. So it's a balance right now. Most of guidelines are holding at age 45, and I think Dr. Kim's going to talk about certain family histories and why those patients get screened a little bit earlier. But if the future trend of cancer continues in younger people, I suspect we'll be reevaluating them in the future, probably seeing more nuanced approaches like stool tests or blood tests. But right now, I think 45 is a good kind of meeting in the middle point.
That's really helpful. Thanks for the insight on that. And it's a perfect segue into our next question, as you mentioned, when we talk about lifestyle choices. Dr. Kim, I'm going to bring this one to you. Are there any colon cancers that are genetic? And as we talked a little bit with Dr. McCune here, and do younger people need to be thinking about their family history? What's important when we think about knowing our family history? Can you talk a little bit about that?
Yes, definitely. As Dr. McEwen said, most of the majority of colon cancer patients are actually not found to have a genetic abnormality or a cause for that. They're what we would call sporadic. So about 75–80% of colon cancer patients or cases are really just sporadic. And so the other part of that are the ones that are of genetic origin. Of those, the main two that we talk about are Lynch syndrome or hereditary non-polyposis colon cancer, and then the other one is familial adenomatous polyposis, so the FAP for short. And so, is it important for young people to get screened and to know their family history? Definitely. I mean, it's important for everybody, I think. I think traditionally it's been one of those taboo topics. In the previous years, people didn't really talk about their illnesses. They didn't like to tell family members that they had cancer, and so everything was very hush hush. But in the modern world, because genetics is such an important factor of treatment and screening, it's so important to investigate that in your family. So, knowing sort of your risks is very important. For young people, I mean, just for again, across the age, everyone should know their family history. But if for young people, whether you're 45 or 30 or 25, if you have any symptoms, rectal bleeding, don't just pawn it off as hemorrhoids. We definitely encourage people to not ignore their symptoms, whether it's bleeding or change in bowel habits or pain, something that doesn't seem quite right. Just get it checked out, because what's the worst that could happen? Well, the worst is that it could be something serious, but on the flip side, it could be something completely fine, but then everybody can feel comfortable with that.
That's
Um, yes, go ahead. Yes.
Oh, that's excellent. Thank you. And I want to move into another question here about screenings and the type of screenings. And I guess one of the questions as we talk about moving age guidelines, how accurate are these screenings as we think about moving this age down? When we talk about genetic cancer screenings, when we talk about regular cancer screenings, how accurate and reliable are these?
Uh, are you talking about genetic testing, you
Yeah,
mean?
yeah.
So genetic testing is usually like a blood test of a panel of genetic abnormalities. So are they accurate? I mean, I guess, usually they're pretty accurate in testing for the abnormalities. The question is how pertinent is that? Just because there's an abnormality or you have a positive genetic test doesn't mean that you're going to get that cancer, but it definitely increases that person's risk. So, as far as genetic testing and predisposition, I mean, that's really what we're looking at, is to look at predisposition so we can advise patients on how to screen, whether it's early screening or more frequent screening. So, for instance, if somebody is tested positive for HMPCC or FAP, those patients would get colonoscopies like every 1 to 2 years, as opposed to every 10 years, which would be the average risk patient.
That's really helpful. It sounds, again, much like you talked about, knowing your family history, more information is better than less, right? That's the best part about this. So
Absolutely.
keeping that in mind, family history is important, and again, knowing that you can set up regular screenings going forward with your physician is very important. I appreciate that. Thank you. Emily, I'm going to move on to the next question. We talked a little bit about lifestyle choices. I think this is important. When maybe you can speak to us a little bit about what types of foods we should be restricting or limiting in our diets that would help reduce the chances of cancer. And then I'd like to ask also, are there certain foods that we should be considering for our diet that may prevent colon cancer?
Yeah, so that's a great question. And, it's something I definitely get asked a lot as a dietitian. Of course, we don't want people to cut out any food group. We really try to not have patients do that because a lot of foods are really important. But if you're going to limit or restrict something, one thing we would say is definitely processed meats. So, like your bacon, sausage, hot dogs, other meats preserved by cooking or curing or adding chemicals. Those are going to put you at higher risk because they can be classified as carcinogens and definitely be a risk for any kind of GI cancer as they're going through your GI tract. Red meat is also another topic of discussion. So, excessive consumption of red meat, we're talking about like beef, pork, and lamb. They've been associated with higher risk of colorectal, pancreatic, and prostate cancers. So, limiting red meat is often advised. So, we'd usually say try and have it like uh, once a week at most, maybe twice a month if you can limit it to that much. But again, red meat's also important because it's going to have iron and it's something we don't want to completely cut out of the diet. Sugary foods and drinks, we want to limit those as well because excessive sugar can contribute to obesity, which is a known risk factor for various cancers. I believe there's another question about this later on in the discussion that I'll go into more detail about that. But the excess sugar is also linked to insulin resistance, which might encourage cancer cell growth as well. Another thing is alcohol. So drinking alcohol in excess can increase the risk of several types of cancers. So for women, we want to limit that to 1 standard drink per day. Men, 2 standard drinks per day. And then highly processed and refined foods. So your frozen TV dinners, packaged snacks, cookies, things like that. They're going to be high in sodium and likely high in added sugar as well. So those are just some things that we're going to want to limit in terms of cancer prevention. And then, yeah, another thing is salty foods. So, like I said, the packaged products, a lot of canned products, frozen products, they're all going to have high salt content because it's a preservative. So, just trying to limit those as much as possible and really focusing on reading the nutrition label is going to be important. In terms of foods that can help prevent colon cancer, We talk about fiber-rich foods. These are really important in moving things along in the GI tract. Of course, having things backed up, like having frequent constipation, is something that we don't want. We don't want things being stuck in the GI tract for a while. So fiber is going to help push these things through. So this can be found in fruits and vegetables, whole grains, legumes like beans, and these can help reduce the risk. And fruits and vegetables are also high in antioxidants, vitamins, and minerals. So these are all good things that are going to help the immune system as well. Cruciferous vegetables like broccoli, cauliflower, and Brussels sprouts are particularly beneficial for colon health. And again, fiber just helps keep the digestive system healthy and supports the regular bowel movements. Healthy fats are going to be another important thing for prevention. They're anti-inflammatory. So these are going to be like your omega-3 fatty acids, such as fatty fish like salmon, flax seeds, walnuts. They've all been linked to lower risk of cancer, again, because they have that anti-inflammatory effect. And turmeric has been found to be particularly helpful because of its active ingredient, curcumin, and it's been studied for its potential anti-inflammatory and anti-cancer effects, especially for colon cancer.
That's really helpful. And I'm already seeing some questions come in from the audience. We're going to talk a lot about anti-inflammatories. Excited to get into some of those live questions and appreciate the audience asking these. So thank you for that. And we talked a lot about, it sounds like, if I could maybe summarize what you talked about there, it sounds like moderation and a variety in your diet can be really beneficial. A lot of fresh foods, fresh vegetables. These are the type of things that we're looking for in a diet. So that's really helpful. I appreciate that. I'm going to move back to Dr. McKeown. I have another question for you, and we may have kind of touched upon this, but I'd like to expand upon it, maybe thinking about different ages. When we talk about how often, starting at 45 is the guidelines as we discussed right now, how often should patients be getting a colonoscopy?
Yeah, thanks, Eric. That's a great question that comes up a lot in our office. So the frequency of colonoscopy depends on who you are and what we find when we do one. So there's no one size fits all rule, but I'll give you the general guidelines in easy terms. So for a healthy adult at average risk, so you meet someone on the street and they tell you they've no family history of colon cancer or polyps or symptoms, and it's either their first colonoscopy or they've had a normal initial colonoscopy, then that's a test that you don't have to do very often. In fact, if we start at age 45 and you have a completely normal colonoscopy, no polyps, nothing concerning, your prep is good, the next one's 10 years. And people say 10 years, that's a long time. But we have a luxury, or colonoscopies have the luxury of a long interval, because when things look good, it turns out that colon cancer usually grows very slowly. So it takes years for even a small polyp to turn into a cancer, somewhere between 7 to 13 years on average. So if we don't see any polyps at all and there's no other issues, we feel comfortable letting you wait almost a decade before checking again. It's kind of like a major home inspection. You get it done once, they check the foundations, everything looks good. You don't need to have it done again for a long time. Now, it's during your colonoscopy, we do find polyps, especially the word adenomas, which is like what patients see usually written on their report or get sent to their PCP. They're what we call the precancerous polyps. We do ask you to come back sooner than 10 years. And how soon depends on the number, the size of the polyps, and the type of polyp. For example, if you've one or two small polyps removed, we suggest your next colonoscopy will be in 5 years instead of 10. If you have multiple polyps or certain types that are high risk, sometimes we say 3 years for the next one. The idea being, if you're someone that grows polyps, we want to keep a closer eye on you and remove any new ones before they can turn into cancer. For example, if you have a high risk factor, strong family history of colon cancer, the schedule's more frequent. So for someone like that, you're never going to get 10 years. You're going to be at least 5. And if we find polyps, it's going to be even closer than that. Patients with inflammatory bowel disease, ulcerative colitis, Crohn's, even closer, like sometimes 1 or 2 years. So that's more specialized. But the bottom line is, if you're an average risk person, your colonoscopy is normal, you're going to be about 10 years.
That's really good to hear. And for the audience, it sounds as if, and tell me if I'm correct here, it's just, there's a very good chance that you get this done, get it over with. You're going to feel better that it's behind you. The advice is don't wait. This is an opportunity to get this done, and you may not have to deal with it again
You're
for
getting
quite
peace of mind. Yeah.
That's excellent. Excellent. And again, thank you for that. Dr. Kim, is there anything you'd like to add to that, or any details? I just want to give you an opportunity to jump in on this one as well.
It's like you were reading my mind. Um, yeah, I was just going to add one thing. Even though I tell patients when they've had a normal colonoscopy and they have no other risk factors, and I say you're good for 10 years, I always add in, however, if you develop any symptoms before 10 years. Don't say, oh, I'm good. She told me 10 years, so I don't have to go back. Then they should call us. So if they have developed any bleeding or if any change in bowel habits, because not all colon cancers behave the same way. Sometimes some can become, can grow more quickly or more aggressively, or if there was a small polyp or a flat polyp that wasn't seen, symptoms could arise. So I just want to emphasize that don't ignore symptoms, even if we've given you a clean bill of health for 10 years.
That's a great point. Things can come up, and certainly your health can change quickly, and we want to keep those things in mind. So great point, and I appreciate the additional thoughts on that one. So, and we're going to continue moving on. We've got a lot of great feedback here. So again, I just want to thank the panel and thank our audience for such terrific questions. I'm going to bring this one back to Emily for a moment. So I want to talk a little bit more about supplements. And an opportunity here to ask, are there supplements and vitamins, protein powders that can assist with cancer prevention? We talk a lot about these, healthy foods and whole foods, right? Variety in our diet. But what other types of vitamins or other supplements can we be considering that could be beneficial for us in cancer prevention?
Yeah, so I want to start that off by prefacing that, of course, we want to be getting everything through the diet. Everything that you can consume through food, as opposed to a pill or a powder or whatnot, is going to be the most beneficial thing to do. And also, if you're going to consume any supplements or powders or anything else that's not natural food, definitely consult with your doctor, your primary care provider, your oncologist before you take any of those, just to make sure they're not going to interact with your treatment or any other medications you may be taking. But something that can be beneficial is antioxidant vitamins, so like vitamin C and vitamin E. They're both powerful and can help protect the cells from damage. So that's going to be something important. But again, it's commonly found in foods. Vitamin C can be found in a lot of citrus fruits, and something that most people are getting enough through diet alone. Vitamin D is another one. So this is crucial for the immune system, and has been shown to potentially play a role in the regulation of cell growth, reducing inflammation, and helping prevent the growth of cancer cells. This is a tricky one. A lot of people in our region, in Pennsylvania and on the northern side of the United States, are going to be deficient in vitamin D. So this might be something that is beneficial to take a supplement. Some people have a hard time getting enough through diet alone. Our main sources are going to be from the sun as well as diet, but it's mainly found in fatty foods. So if you're going to have fish or something like that. But again, a lot of us that live in this region are going to be deficient. So that is one that I would say get your levels checked if you think you might be deficient. And if you are, consider taking a supplement. And again, consult your doctor about that first. Another one that could be helpful is folic acid or vitamin B9. So this plays a key role in DNA synthesis and repair, but again, we usually get enough from our diet. It's fortified in a lot of foods like cereal and things like that. So usually not something we recommend having an additional supplement for. Omega-3 fatty acids are going to be important. Again, I mentioned this before. They're really important for anti-inflammatory, but they're going to be found in your fish, your fatty foods, avocados, things like that. So some people might take fish oil as a supplement to get these fatty acids, but again, usually you can get enough through diet. And then probiotics can be beneficial. We have been talking about the gut microbiome, and probiotics are going to be the healthy bacteria that help your gut microbiome. So these can be beneficial to improve the good bacteria that we have in our gut, but it also can be found in food. So if you're going to eat like Greek yogurt, kefir, any fermented foods, they're going to have live probiotics in them. So again, that's something to consider as opposed to taking, a supplement or a pill for a probiotic. Again, like I said, whole foods going to be better than supplements. Consult with your healthcare provider, and obviously excess supplementation can have its harms as well. So definitely don't want to overdo it. And again, I would just recommend talking to your healthcare provider before taking any supplements.
That's really great. It sounds like we want to rely more on those whole healthy foods rather than the magic pill of the moment, right? That's good advice. I appreciate the thorough answer on that. So thank you. Dr. McKeown, we're coming back to you here. So I want to ask the question, can someone prevent the reoccurrence of colorectal cancer, right? So you've been diagnosed and you've been treated, are there things that we should be thinking about in terms of reoccurrence and how to avoid it? And then, what are the chances of reoccurrence with stage one colorectal cancer? What about other stages? Is there something you could tell us a little bit more about in that?
Sure. Yeah, I feel like we could have a whole hour on this, but let me say first of all, for anyone that's gone through colorectal cancer treatment or has a loved one, we understand how scary that word recurrence is. It's like a very common concern. Patients come to the office and they say, "Look, I beat this once. What are the chances of it coming back, and what can I do to stop it?" So the chances of it coming back depends largely on the initial stage of the cancer. So that's the stage of diagnosis, and the lower that stage, like you said, stage one, stage two, three, four being higher depends on your recurrence. So for stage one, where the cancer was small, confined to the inner layers of the colon, that has a very high cure rate. Most stage one patients, once they have surgery to remove that cancer, will stay cancer free. The likelihood of it coming back in stage one is in the order of single digits. So when we get those patients to 5 years, we say, you're cured. For stage two and three cancers, the recurrence is a little higher because the disease was more advanced to begin with. So for stage two cancers, usually it's involved in more deeper into the colon wall, and stage three means it's gone to lymph nodes. But with modern treatments, we still cure many of these patients, but we just have to be a little bit more vigilant. So roughly, if you take about 100 people with stage two colon cancer, about 15 to 20 of those people may see the cancer return after their initial treatment, whereas 80 to 85 of them will be fine. For stage three, it's a little higher on the order of 30% of recurrence over 5 years. That's why stage three patients, the one I mentioned, which spreads to lymph nodes, they typically get chemotherapy after surgery to knock that recurrence risk down as much as possible. So in other words, stage three patients still have a very good chance of cure, but some will recur, and we're improving those odds with chemotherapy in new patients. Now, when you get to stage four, which is what patients typically know as metastatic disease, where the cancer is spread to other organs, typically the liver or the lungs at the time of diagnosis, it's a little bit more of a complex situation. It's not, stage four isn't usually curable in the traditional sense, except in certain scenarios where, say, disease in the liver is small enough to be resected. Oftentimes, stage four patients will have ongoing treatments, and the concept of recurrence is a little different. It's more about controlling the disease. But for the earlier stages, like I said, we aim for cure, and we say if we get you to 5 years, we typically say you're cured at that point. Now, can someone prevent recurrence? The honest truth is there's no guaranteed way to 100% prevent a cancer from coming back. It can be sneaky. Even if there's a few cells left in the body, they can regrow, which is completely out of a patient's control. There are steps that you can do to lower the chance of recurrence or catch that recurrence early as possible. So that way we can treat it, sooner. So you stick to all your follow-up appointments. You make sure you come back to see us 3, 6, 12 months. You come back at least once a year. You get your follow-up colonoscopies, your follow-up blood tests. You maintain a healthy lifestyle, like Emily was talking about earlier, certain types of foods that you want to avoid and certain types of food that you want to take. So avoid smoking, limit alcohol. Smoking is certainly a risk factor for not just recurrence of cancer, but for developing new cancers. Same with alcohol. Heavy drinking has also been associated. So all these lifestyle changes not only potentially reduce the risk of cancer returning, but as I said, they just improve your overall general health. And they give you a sense of control that you're doing something proactive for your health, which is empowering. So I just want to emphasize that stage one patients should feel very optimistic all the time that the cancer's gone for good. Stage two and three, many will also do very well, but it's important to follow the guidance on chemotherapy and follow-ups and keep up with healthy habits.
That's a great summary, and it sounds, again, staying in touch with your physician and making sure that we're thinking about prevention and screening early and catching it early is even more important. So great summary there. Thank you. Dr. Kim, is there anything you'd like to add to that as well?
Yes, I'd just like to emphasize what you just mentioned, actually, is staying in touch and with your doctors and doing the follow-up as recommended. Because we have many patients who, for one reason or another, have been lost to follow-up, and that's where we run into these issues and troubles because we haven't been doing the follow-up colonoscopies or the CAT scans or blood work. And so it is so important. I usually tell my patients that it's kind of a lifelong relationship that I develop with a colon cancer patient, even if they've been cured. And even 5 years later, we see them, every at least every few years, 3 to 5 years for another colonoscopy, and just really kind of keep on that because the earlier you detect the recurrence, way better the outcome.
It sounds like, something we say a lot at Jefferson, and building a relationship with a physician is ever more important as you age. So great point there. And I'm gonna stick with you on our next question. This may be a little bit of a repeat of some of the questions we asked before, but I do want to make sure that we ask it again. Our audience submitted these. So we talked a little bit about family history of colon cancer. We talked about having someone with no abnormalities. Screenings. We just want to kind of reiterate this again. Can you talk a little bit about the necessity of screening every so many years at lifestyle ages?
Well, specifically for average risk, as we said, was 45. If somebody has a first degree relative, parents, siblings, or even if you're an older parent, you have a child who was diagnosed with colon cancer. So anybody first degree relative of yourself, that's considered high risk because it's family history. So that person should get screened every 5 years at least, and maybe even more frequently depending on the findings of the colonoscopy. And then as far as when to start, so if the patient's family member had cancer at say 45, then it should be 10 years prior to that they should start, and then every 5 years. So 35 and then 40, 45, etc. If the family member had colon cancer diagnosed at 60, then it's recommended to start at 40
Mhm.
instead of 45 and then go every 5 years. So assuming again that everything is normal. If with the other genetic colon cancer syndromes, as I mentioned before, it's much more frequent even. And with some of the HMPCC, we even have patients with that particular genetic abnormality. I mean, they start at age 20 to 25. With FAP, it's children, 10 to 12 years of age is when they would start screening.
So regular screenings, it really depends on your circumstance. That's
Right.
okay. Great. Thank you very much for that. Emily, I'm coming back to you with another one here, and we want to talk. We're going to get into questions about reducing inflammation. So, what can someone eat to reduce inflammation that was seen in a colonoscopy? Is there a change in diet that could impact that?
Yeah, so for sure. Again, like I mentioned, those omega-3 fatty acids are going to be really important in reducing inflammation as well as the fiber-rich foods and the probiotics as well, especially if we're talking about the gut here. The probiotics can be helpful in reducing that inflammation. Other two nutrients can be turmeric, like I mentioned before, and ginger can also be helpful for reducing inflammation in the GI tract. So for ginger, if you want to drink ginger tea or
Mm.
take some ginger and put that in like hot water and boil it over and drink that, that can be helpful. Again, your leafy greens and vegetables are going to be important, fruits as well. Some anti-inflammatory fruits are going to be berries like blueberries, strawberries, and raspberries. Apples with the skin can be helpful. Grapes, orange, and citrus fruits, as well as cherries, can be helpful for anti-inflammatory. Another thing could be olive oil. So I think we're going to talk about the Mediterranean diet at some point. And so olive oil is going to be a key staple in that diet. It's very important for anti-inflammatory. Green tea can also be beneficial. So, there's research out there that if you drink a cup of green tea a day, that can be very helpful in lowering inflammation levels in the body. Bone broth can be helpful. And coconut oil also has that medium chain triglycerides, which is an important nutrient for anti-inflammatory. And then just avoiding inflammatory foods. So, refined sugars and processed foods can promote that inflammation. So, trying to avoid those. Avoid excessive alcohol and caffeine as much as possible. Trying to avoid fried foods and those high in trans fats because those can exacerbate inflammation. And dairy for those who are lactose intolerant or certain high fat dairy products can irritate the GI tract. So trying to choose low fat options, no fat options, or even some dairy alternatives might be a better option for, keeping the inflammation down in the GI tract.
This is great. I hope the audience is taking a grocery list because I'm going to start my grocery shopping list now. So thank you for this. This is really helpful. And I'm going to stick with you on the next one, Emily. You'd mentioned the Mediterranean diet, and that is the question directly. Is the Mediterranean diet the best for anti-inflammatory disease?
Yeah, so it is very well known for anti-inflammatory, and it's probably the most well-known one out there. So it is considered one of the best dietary patterns for reducing inflammation, and it really emphasizes whole nutrient-dense foods and is rich in the anti-inflammatory ingredients that we just went over. And these can help support overall health, including reducing chronic inflammation in the body. So some of the key things that it has is those healthy fats. It's high in monounsaturated fats. So when we talk about fats, there's a few different classifications. There's monounsaturated, polyunsaturated, and then your saturated fats. We want to limit saturated fats as much as possible, but the monounsaturated and the polyunsaturated, those are going to be more beneficial and anti-inflammatory. So one of the monounsaturated fats is going to be that extra virgin olive oil, which the Mediterranean diet really emphasizes. So cooking with that, adding it to like salad dressings and things like that is going to be a key staple there. Again, promoting fruits and vegetables, trying to get, 4 to 5 servings of each a day. Whole grains are emphasized in this diet. So quinoa, barley, whole wheat, other fiber sources. It also emphasizes legumes and nuts, so like lentils, beans, chickpeas, or almonds and walnuts. And then herbs and spices, it really uses a variety of these, such as garlic, turmeric, basil, oregano, and cinnamon. It emphasizes moderate intake of dairy, so primarily from fermented sources like yogurt and cheese. Again, the yogurt's going to be a source of that probiotic for you. And then it does also talk about red wine in moderation. So moderate consumption of red wine is sometimes included in this diet. It contains resveratrol, which is a polyphenol. It's an anti-inflammatory and it has antioxidant properties. So again, it is talking about alcohol, but we want to do that in moderation. So usually not more than a glass of wine a day. But many studies have shown that this diet can help lower inflammation markers in the body.
Again, great information here and appreciate it. I was trying to put off the fact that I skipped dinner tonight, but now I'm getting hungry, so I appreciate it. Thank you for this information. So, Dr. McCune, we're headed back to you with this one, and we're going to talk more about polyps. If someone had polyps removed during a colonoscopy, how likely is it to come back and turn into cancer? This kind of touches upon the discussion we had just a few moments ago.
Yeah, great question, Nick. First, let me clarify, when you go for a colonoscopy and the doctor finds polyps, which we already mentioned, small growths in the lining of the colon, removes them. The first reaction is often, well, phew, they took them out before they became cancer. But then patients get worried. They say, does this mean I'm going to grow more polyps? Are they going to come back? Am I going to get cancer later? So this question's aiming at that concern. The good news is when we remove those polyps, they're gone for good. Those specific ones are not going to come back. They were snipped out. It's kind of like removing a mushroom grown in your garden. That actual individual mushroom is not going to grow in the same spot again once removed. And by completely removing those polyps, especially the adenomas, we drastically reduce the risk of that polyp ever turning into a cancer. But in fact, only a small fraction of these polyps actually do progress to turn into cancer, even if left in place, about 5% on average. And it takes, as I said earlier, many years for this to happen. So taking them out earlier is a huge preventative step. However, when you've had polyps, it does signal that your colon's environment is friendly to growing these things. In other words, we call you like a polyp former. And yes, unfortunately, that means you're at higher risk of developing polyps in the future. It's not so much, as I said, that they're going to come back, but rather new ones are going to form elsewhere in the colon over time. And how likely is this? It varies with how many polyps you've had, what type, your lifestyle, but some rough stats, it's approximately a 25 to 30% chance that when you come back for your next colonoscopy, whether it was 3 or 5 years later, that we'll find additional polyps that weren't there or were too tiny to see the first time. There's about a 1 in 3 chance of those new polyps forming within a few years. So if you've had a lot of polyps initially, the chance of finding more can be even higher. But if you've only had one tiny polyp, your chances on the lower end of that range. Because of this propensity to grow polyps, if you've had these removed, we will put you on a surveillance schedule, not a screening schedule anymore. Typically, your doctor will ask you to come back in 3 to 5 years, as I said, rather than the 10 years. This way, if new polyps sprout up, we can remove them while they're still small, still benign, and prevent them from turning into cancer. It's one of the reasons colonoscopy is such a powerful tool. It's not just finding cancer, it's preventing it by weed pulling, so to speak. So imagine, your colon's a garden and the polyps are these weeds. You pulled a few weeds this time, remove the polyps, but the soil in your garden might be so that it's like, well, it's more prone to growing weeds again in the future. So the key is to keep tending the garden at regular intervals, which are your colonoscopies, checking again and, keeping them tidy, choking them off and making sure that's like a prize garden with no weeds whatsoever in it. Um, how likely is it that if we don't do it, that they'll, turn into cancer? If you follow the plan and remove new polyps, the goal is zero cancers. The entire rationale of the polyp removal and surveillance is to stop it from ever growing. But if someone had a polyp removed and then didn't go for a colonoscopy for 10, 15 years, there's a risk in those patients that a new polyp could develop over time and silently grow and become cancerous. But with proper follow-up, the risk of colon cancer is greatly reduced. And studies have shown that patients who undergo regular surveillance after polypectomy have significantly lower rates of cancer than those who don't. So to sum up, I would say polyps removed means problem solved for now, but new polyps can occur in about 1 in every 3 or 4 patients within a few years. So fortunately, we're always on the lookout for them. So as long as you go to your follow-up colonoscopy appointments and get them removed, you are very unlikely to have polyps turn into cancer. Colonoscopy really cuts the chances of that down dramatically. But like Dr. Kim said, same thing. Every time we see a patient, we say, hey, listen, doesn't matter whether or not it's a year from now, 6 months from now. If you feel something's off, something's different, you come back and we get it earlier because there are very small ones that can be missed. And if you're a polyp grower, a former, we don't want to see something, come out of the blue that could have been prevented. So always, come back and see us if there's something that it feels a little bit off.
Again, great advice, and thinking about the importance of staying in touch with your physician, the importance of getting those colonoscopies on a regular basis when those milestones take place, and just such a great analogy too for it when you think about all of the circumstances. This leads me right into my next question for Dr. Kim. When we think about how do we keep that garden healthy, right? When we think about this, is there, Dr. Kim, is there a connection between diet and the development of polyps, and is that tending that garden, as Dr. McEwen said? Is that something that diet can really focus and make a difference in that garden?
I feel like we're just saying the same thing over and over again as far as diet, because really the answer is the same thing that we've been talking about. Overall, studies are showing that that decreasing like red meats to maybe once, yeah, a week, decreasing fats, increasing your fiber intake, increasing your roughage, decreasing, tobacco or no tobacco use if possible, but decreasing alcohol use overall, weight loss, keeping weight at a stable level if you are already at a good level and not weight gain. So all these things seem to decrease the risk of colon polyps and also colon cancer because, basically they kind of go hand in hand. If you have colon polyps, that's basically precancerous, then, you have the higher chance of getting colon cancer. So those are really, again, it's the same kind of stuff that Emily just had mentioned before. Anything, basically it just includes all the foods that keep your bowels moving. We don't like things to be stagnant. And that's where the fiber comes in. There was some sort of question of whether high dose calcium and things like that, or foods high in calcium or supplements could decrease or increase the risk of polyps. The jury's kind of out on that. It seemed like for a while, uh, it was recommended to actually take high dose calcium supplements. And then there was some question of actually were polyps, is the risk of polyps actually higher with calcium? So really I think there's no definitive correlation right now that we have found. But in general, it's basically what we just have been saying already all night long about the diet.
And that's great. We, again, as many of these questions coming from the audience, it's great that they're asking the same question. So hopefully we're answering them. And again, I appreciate these detailed responses from our panel this evening. So thank you for that. And with that in mind, as we start to get into these live questions, I'd like to start with some more specifics. And I love this first question. It's something that we hear about frequently when we hear about diet, and we hear about many of the some trends that exists, but around nightshade vegetables. So Emily, I'm going to bring this one to you first, if that's okay. And if you wouldn't mind talking the question from the audience as we get into our live questions here. What do you think about eliminating nightshade vegetables as a way of decreasing inflammation?
So I honestly haven't heard too much about that. I know some of the vegetables that are in that category, but I believe if you're consuming enough of the anti-inflammatory foods that I went over, keeping your fruits and vegetables high, your fiber high, consuming those omega-3 fatty acids, and really just having a well-balanced diet, I don't believe that cutting out a certain group is really going to have that much impact. If you are consuming enough of the anti-inflammatory, that's going to be able to counteract any inflammation that might be caused, by those other vegetables in that category.
That's great. Thank you. Thank you. Appreciate the insight on that one. I've heard a lot about that one personally, so interested to hear your response on that. Thank you. Dr. Kim, I'm going to bring this one to you. This is another live question. I had a colonoscopy after having C. diff. Some inflammation was seen, but I was told to have another colonoscopy in 3 years. Can C. diff cause temporary inflammation?
Yes, I mean, C. diff is colitis, which is inflammation of the colon. So I imagine that the endoscopist had seen some inflammation of the colon, and maybe the biopsy showed C. diff on the microbiology studies. So, sure, definitely could cause temporary inflammation, which usually does resolve either on its own or with antibiotics and or probiotics. Sometimes C. diff can be pretty stubborn and need prolonged antibiotics or even, to the extent of having fecal transplantation. But in general, it's well it sort of self-resolves, and then at some point another colonoscopy should be performed. And my guess is that the endoscopist probably did not want to be too aggressive about looking very well or biopsying or pushing too hard in a colon that's inflamed. So they would want that person to come back when things are settled down.
Great. Thank you. And Dr. McKeown, I'm going to bring this one to you as well. We talked about changing the age for recommended age for colonoscopy. I don't expect you to be an insurance expert at this either, but one of the questions here is about coverage for someone under the age of 45 for colonoscopy with their insurance company. Do you anticipate or expect, or are you aware of anything in the market that may find that easier for someone under 45 to get that covered by their insurance in the future? We'll just unmute you there for 1 second.
Sorry. The question, I guess it really depends on what the reason is. And now, if it's someone who's coming in and doesn't have, their average risk, they don't have the family history, they don't have a history of polyps, they never had a colonoscopy before. Well, it's hard to convince that insurance company to say, well, I need my screening. I always equate screening to, say, dental checkups. I say, you go get your cleaning twice a year, and that's covered under your insurance because it's preventative care. Now, but if that's different, if that patient comes in and says, I'm having rectal bleeding, I'm losing weight, that absolutely is covered by their insurance because that's the whole reason to have insurance. But it's a different reason. It's a diagnostic colonoscopy. So no insurance company is ever going to turn around and say you can't have a colonoscopy if there's a reason. But if you're coming in just saying, I feel like getting a colonoscopy, even though I have no symptoms and I'm 35, I'm 43, whatever. I mean, that's when you run into a little bit of trouble. And I think they would have issues getting that covered with their insurance, unless they have some very, very great insurance company, which is very easy to deal with. So
Great response. And again, I think that sounds like there's an importance element there to paying attention to your symptoms and bringing that to your physician. Dr. Kim, would you like to add something?
Yeah, I just from having, experienced some of the issues that patients would have with screening versus diagnostic. I'm not sure if this is what the questioner was asking, but there is a difference potentially in copay. And so a diagnostic colonoscopy may not be fully covered versus a screening colonoscopy. And so that may be the question. I'm not sure if that's the question, but so it may, they may have, a patient may have some financial responsibility for a diagnostic colonoscopy. That would be the only thing.
Great point. I appreciate the details on that. Thank you again. And Emily, I'm going to bring this next one to you. So specific question about diet soft drinks and whether or not those contribute to colon cancer risks more so than regular soft drinks.
Yeah, at this time, I don't think there's really enough research out there. Obviously we know the effects of sugar, and then we look at the effects of artificial sweeteners and sugar alcohols and whatnot. And they're not, 100% the best either. So my answer to that is really just everything in moderation. Of course, water is going to be your best friend if you can, limit sugar sweetened beverages or artificially sweetened beverages and just drink water. That's going to be your best bet. But if you can't do that, then of course, just trying to limit them as much as possible, whether it does have the sugar or the artificial sweeteners. We really just don't know enough about the effects of it right now that anything in moderation is going to be important.
That's great. And again, appreciate the reoccurring message there. Moderation is key over everything when it comes to your diet. So again, appreciate that. Dr. Kim, I'm going to bring this next question to you. I want to talk a little bit about this is coming again directly from the audience. Let's talk about the risks of colonoscopy. How safe is the procedure, and are there any risks involved with the colonoscopy at all?
Yes, of course, there are risks with everything. So starting from, the bowel cleanse itself, you have typically we have our patients do a 24-hour period of being on clear liquids and doing some sort of laxative preparation, whether it's a liquid type of prep or an all tablet type of prep. So that in and of itself can cause some issues with electrolyte abnormalities, diarrhea, causing dehydration. Some of our more frail patients could be at risk for renal failure and having syncope, et cetera, et cetera. So that's the first risk, although that is, fairly low. And of course, as we encourage hydration and a significant hydration during the prep process, very few people have issues during that period. The next step would be the procedure itself with the anesthesia. It is done under IV anesthesia, sedation, so patients are monitored, but they're asleep for it. And when you are asleep with anesthesia, they have certain things that they can't protect. They can't protect their airway as well. So if there is mucus or fluid in their stomach, or if they have an upper respiratory infection, then that can cause some upper airway issues, whether it's aspiration or laryngospasm or all kinds of things. So again, very low risk, but that can happen, but that is a risk. And then for the colonoscopy itself, which is what most people think of as the big risk, is perforation of the colon, which is probably the lowest risk of all of these things that I'm mentioning. Nationally, I believe it's probably less than 0.03% or something like that. Or, I mean, it's pretty low. We're talking not zero, but almost zero. Maybe not 0.03, maybe it was 0.3% actually. I'm sorry. So that risk is there, but again, very low. Risk of bleeding if we have polyps that need to be removed, especially when they are large polyps. If somebody's on anticoagulation medication, all these things can increase their risk of bleeding. So that is what I think Dr. McKeown was referring to, that, we don't want to just do colonoscopies willy-nilly. They are, as every procedure has, they do have some risks as well.
It's great. So again, it seems as though the benefits certainly outweigh the risks there. The importance of screening is just, we're going to continue to drive that point home this evening. So Dr. McKeown, I'm going to bring this next question to you again, live from the audience here. Are there alternative screening options for those who may not wish to go the colonoscopy route?
Yeah, so there are several. So some patients can undergo what's a flexible sigmoidoscopy. That's a kind of a mini colonoscopy. Sometimes that can be done without sedation. The patient doesn't have to take a full prep necessarily. They can take enemas, but unfortunately, that only covers the left side of the colon as far as you can, get usually to about 40 to 60. So the benefit is you're ruling out anything on the left side of the colon, but not necessarily screening the rest of the colon. There are tests. There are what's called a FIT test, which is where they test for an enzyme that reacts with hemoglobin, which is part of the blood. So if there's blood in the colon that shouldn't be there, the FIT test can pick that up. And then that's usually, it's a precursor to tell you need a colonoscopy. So a lot of these tests are, as I said, if they're negative, then you can get a little bit of peace of mind. But they typically, if they're positive, you still end up needing a colonoscopy anyway. Another thing that can be done, and what people are very familiar with from all the commercials, is the Cologuard test. And the Cologuard test is nice in that, patients can do it at home. It tests for DNA, which are found in polyps. So it's specific for that. The problem with Cologuard that we see is that it has a fairly high false positive rate. So it'll be positive, and then we go do the colonoscopy and we can't find anything. And it's very frustrating for us because, if it's positive, even if we find a tiny polyp or a cancer, we want to find something. So, and to touch back very briefly on what Dr. Kim was talking about diagnostic versus screening colonoscopies, sometimes when patients get a Cologuard and it's positive, some insurance companies will classify that as their screening test. And then when they go to get a colonoscopy, they may have to be financially responsible for it. Now it's a diagnostic colonoscopy because now we're going to look for something that was found on a diagnostic test. Other things that patients are probably may be familiar with are CT colonoscopies. That what a CT colonoscopy does is you don't have to get the colonoscopy performed under sedation, but you do still have to take a bowel prep, what Dr. Kim mentioned earlier, and they typically inject contrast into the colon and they look for any polyps. They're pretty good at finding polyps that are, close to a centimeter in size, between half a centimeter to a centimeter. But again, the problem is if it's positive, you need to go have a colonoscopy. So now you've taken a bowel prep, you have this test, shows something. I have to take another bowel prep, get a colonoscopy anyway. So, I mean, I know we're biased as surgeons and endoscopists, but we typically lean more towards the colonoscopy because it's diagnostic and therapeutic.
Right, a trusted solution that you use as a physician to be able to find these things and identify them easily with patients. So that makes perfect sense. And this question may be a repeat of what we just talked about, but Dr. Kim, the question here from the audience, are there markers in blood panel tests that should be watched and may indicate colon cancer?
I mean, I guess the most common marker would be a drop in hemoglobin. So somebody who is anemic, without any good explanation for the anemia, would be recommended usually to have a colonoscopy, assuming they hadn't had one recently, or an upper endoscopy, because tumors, colon cancer specifically, can bleed ever so slowly and ever so gradually, but enough to create a decrease in their hemoglobin, and or iron. So that would be one. There are some research being done on circulating DNA of colon cancer. And that's in the works as potentially a way to either diagnose or follow patients with colon cancer. It's already being used to some degree in the oncology setting as a way to help decide when somebody needs chemotherapy or the duration of chemotherapy after surgery for colon cancer. So those would be my two. Dave, can you think of any other blood testing?
We'll unmute Dr. McCown there.
Oh,
No, I agree. I think circulating DNA is probably going to be the way in the future. Like we talked about earlier, instead of, necessarily dropping the screening age to 35, we may just be testing for circulating DNA in higher risk patients with family history. But no, I can't think of anything else from a blood test perspective.
That's great. Thank you both very much again for the specifics on this. I'm going to bring this next one back to Emily. We're going to talk a little bit about a very commonly debated topic in energy drink consumption. So is there any connection that you're aware of between colon cancer and energy drinks?
Again, I don't have a specific answer for you, but as we talked about before, caffeine and alcohol, of course, most energy drinks don't contain alcohol, but caffeine, and excessive use can be a risk factor. So trying to limit your caffeine intake as much as possible. And again, a lot of these energy drinks are going to have those artificial sweeteners in them. They're marketed as zero sugar and whatnot, but they do have the sugar alcohols, the artificial sweeteners. And again, we don't know too much about the risks of those. So again, a repetitive answer, but just anything in moderation. Try and limit your caffeine as much as possible and your consumption of anything that's, not going to be just water, in terms of beverages.
This is great. A lot of reoccurring themes here on our webinar tonight in terms of moderation and staying diligent with your screening. So I think our audience is getting the message loud and clear here this evening. So I do appreciate that. We talk a lot about lifestyle changes tonight. So there are two questions. I'm going to combine these as we come to the top of the hour. One of these being, are there any other cancer risk reduction lifestyle changes that maybe we didn't talk about tonight? The audience member here specifically asks about sleep, the benefits of sleep and cancer prevention, or anything else that you'd like to talk about. And I'm going to open this up to the whole panel if anybody's interested. And then I'm going to ask one more question more specifically about obesity and colonoscopy. The audience member asks about any struggles with a patient who may be facing obesity, is putting this off because of concerns that their obesity may make a colonoscopy more challenging. So, Dr. Kim or Dr. McKeown, do you want to cover the colonoscopy question and answer that in any fashion?
Yeah, I mean, I think when we do see patients from time to time that, you know, obviously do have issues with obesity or struggling with it, but usually what our biggest concern is not so much doing the colonoscopy or having a technical difficulty. It's more that protecting their airway. A lot of the time, patients may have issues with sleep apnea, and as such, they wouldn't be, safe to undergo the colonoscopy or get sedation in one of our surgery centers. So we typically would perform that colonoscopy in the hospital, and it's not any burden. It's not any different than any other patient whatsoever. It's just that the anesthesiologist maybe keeps a bit of a closer eye on them. And, if anything happened, you're in the hospital setting where if they needed to potentially have their airway protected, we could do that in the hospital setting. But I don't think there's any reason why those patients should feel that they shouldn't undergo a colonoscopy or that it's going to be a burden to anyone else. So no, absolutely not. I think it should no different than any other patient.
Wonderful answer there. And that's exactly what we want to hear is the reminder that no matter what the circumstances, we've got the ability to take care of every patient. So appreciate that very much. Thank you. As again, we're coming to the top of the hour here, and I want to move on to what will be our final question of the evening. And we talked about a lot of things here. And again, I do appreciate the panel very much so, and many great questions, many great answers here. So this last one I want to get into and ask, we'll start with Dr. McKeown, for the final question, what are your goals for our audience and our listeners this evening? What is it exactly that you would like our viewers to take away from tonight? Again, we talked about reoccurring themes. So tell me, what do you want viewers to take away from this?
I think, the most important thing is don't be afraid to get a colonoscopy. It's a very safe procedure. We did talk that there's risks with anything. There's risks with crossing the street, but it's a very safe procedure. It's time tested, and it's been proven to decrease the risk of mortality. So I'm not as adept or clued in as Emily would be with the nutrition side of things, but from our perspective, we want to make sure that everyone who should get screened is getting screened, and whether that's having a conversation with your primary care doctor, even if that means get a Cologuard, get a fit test. You should. This is a very, very preventable cancer, and there's absolutely no reason why we should see someone come into the hospital at age 70 with a horrible colon cancer that could have been prevented. And I think, especially in the Jefferson system, everything is so linked and everyone is so interconnected. You see your PCP, you can be in to see us the next day. You can be in to see us that evening. So I think that's access is not a problem. Patients should not be afraid to get their colonoscopies from whoever.
It's a great point in terms of access. We have many very talented physicians wherever you may live in the Delaware Valley. So great point. Dr. Kim, same question. What would you like our viewers this evening to take away from the webinar?
Yes. Well, I'd like everyone to know that we, especially our group, very accessible. We, like Dr. McKeown said, we will see patients that day, that evening, the next day, if there are any acute symptoms. So it is so important to not ignore them. And, other than just the routine, timely colonoscopies and screening, if anybody has any symptoms, we really just don't want people to ignore them. And even if it ends up being completely nothing, completely benign, we have the ability in our office to at least at the most, do a flexible sigmoidoscopy. So we can, rule out rectal cancer right there in the office. For a colonoscopy, you have to go through the prep and all that kind of thing. But really, rectal cancer has been on the rise for young patients, especially. Particularly rectal, more so than colon. And so I just don't want people to sit at home and ignore rectal bleeding and think that they're hemorrhoids.
Another great point. Again, not ignoring your symptoms and getting in touch with a physician can be very easy. So great point. Again, reoccurring themes tonight. So Emily, same question. What would you like our viewers to take away from tonight's webinar?
Yeah, so again, everything in moderation. I really think it's important to try and consume the most amount of whole foods as possible. Cooking everything yourself, buying fresh fruits and vegetables is going to be your best bet. You hear a lot, if you can't read some of the ingredients, it's probably not the best food for you. So again, trying to be able to read the ingredients, make sure that the things that you're buying have, the most natural products in them and ingredients. And again, just increasing fruits and vegetables, the fiber is going to be really important, especially for the GI cancers. And just trying to, limit your saturated fats, the processed meats, and the caffeine and alcohol and things like that.
Wonderful. Again, great answers. Appreciate our panel this evening and want to thank our audience for these tremendous questions. So again, thank you, Dr. McCune, Dr. Kim, and Emily for your time this evening. A lot of great questions. Thank you all our audience, and really appreciate you submitting these questions. We couldn't possibly do this without you, so thank you for all of these great questions. We will be posting an event survey so you can let us know your thoughts about the webinar. Any specialties that you want to hear from, please think about that. What webinars would you like to see in the future? If you'd like to contact someone directly to schedule an appointment at Jefferson Health, please fill out that last question in the survey. So look for that coming shortly. And be sure to visit jeffersonhealth.org to make an appointment. Staying up to date, much like we talked about in the webinar this evening, find a physician and make sure you build a relationship with them. We have upcoming events and webinars that you can find on jeffersonhealth.org as well. And also please consider visiting jeffersonhealth.org/livingwell. Lots of great health content, patient stories, research, and innovation taking place at Jefferson. And please be also sure to visit our YouTube page. Our Jefferson Health YouTube page has many more wellness webinar series events, much like this one. We have a variety of topics from back pain to robotic surgery and hearing loss, lots of topics on men and women's health, and many things that you're going to find interesting there. So please feel free to check out our YouTube page. Last but not least, a recording of this event will also be sent to you so you can rewatch and feel free to share with friends. If there's anything anyone at Jefferson Health can do for you, please feel free to reach out to us. Thank you once again for joining, and please be sure to stay safe and stay healthy.